This seminar, unfortunately, will be quite short, just 2 hours or so. So please keep your time discipline. The speakers will talk about this perhaps, but Golisano Institute was founded in 2018. Thanks to the resources of Mr. Golisano, who has a son with a mental disability, and his idea was to transform the healthcare system to provide the best quality care for such persons. Thank you very much. Thank you very much, Professor. Now, let me have His Magnificence Rector of Medical University in Lublin, Professor Wojciech Załuska. Madam President, ladies and gentlemen, representatives of the authorities, institutions, associations, unions that gather together to create the fundamental part of our healthcare system, whatever you call it. The group of healthcare professionals acting together to benefit our patients. I'm extremely proud that it is our university, the Medical University of Lublin, is the organizer of this meeting, this seminar. Professor Dobrowolska and Dean Wysokiński are a team providing excellent educational platforms addressed to both healthcare professionals, to students or candidates for medical courses, for nursing at our health sciences department. And I'm sure that the idea of this very meeting, that is intellectual and developmental disability care, for patients, that we do our best to treat and take care of as much as we can. I can tell you from my experience and experience in my teamwork and cooperation with our nursing teams, excellent nursing teams, one of the best in the world, really. So, top notch, and I honestly have had, a lot of offers to have our nursing teams kind of moved to the USA. I wouldn't like to boast about it to our American friends, but this is a fact. And our nurses have the longest service in the world, and that's why they have the longest time of contact with the patients. And I have worked in Germany, in the US, and I have a patient who has been on dialysis for 40 years. So could you imagine that? Of course, she suffers from some disabilities as well, and suffers from the effects of the long-term treatment. But this is a challenge for us. Thank you very much for being with us at this event. I hope it will be fruitful, productive. As Medical University, we are one of the leaders in promoting healthcare professionalism. Our students learn in groups, in teams, and are highly successful.
Because this is the great pleasure for me to see our friendly guest from the USA representing distinguished institution from Rochester. So thank you so much to be with us. And I think that I be educated, had the opportunity to be educated in the United States also for many years. And I know how this is important. And I'd like to say I can offer you to be our visiting professors. If you're happy, we are very open. We would like to have so many people from the USA institution be with us, looking for our education, progressive and our clinical involvement. So thank you so much for being with us. Ja jeszcze raz bardzo gratuluję organizatorom, wszystkim.
And once again, congratulations to the organizers and participants. And again, I would like to wish you all productive confrontations, so to say, with our reality. And once again, I'm really pleased to be a representative of the hosts of this event. Thank you. Thank you very much. And let me have Deputy Mayor of the city of Lublin, Anna Augustyniak.
Magnificencjo rektorze,
Your Magnificence,
panie prorektorze,
Mr. Rector, Pro-Rector, Dean, Pro-Dean,
szanowni państwo,
Madam Professor,
prezeski, prezesi.
ladies and gentlemen,
Niezmiernie miło, że mogę uczestniczyć
it's an honor to me to be part of this seminar.
że razem ze
I'm
mną
really
są
glad
moje
to
współpracownice z
see
Wydziału Zdrowia, które
my
na co dzień
co-workers
zajmują się
from the health
między innymi
department
taką problematyką.
who
Szanowni państwo, chciałam na
take care of
serdecznie
such
pozdrowić
tasks
państwa
on the
prezydenta
everyday
miasta Lublin, doktora Krzysztofa
basis.
podziękować
Many
za to,
greetings
że
from
to seminarium
the mayor of the Lublin city,
tutaj
Krzysztof
u nas w
Żuk.
mieście
We are really
inspiracji.
glad to host this event in Lublin as the city of inspiration, perhaps.
Jest mi ogromnie miło,
You will know that Lublin is the city of inspiration. So it's an important event, this seminar, and the presence of distinguished guests, experts, academics from medical universities, both in Poland and abroad. It's a great honor to be among you here. And the activity of our academic society builds the brand of Lublin and the region as an important academic center in Poland and abroad. And cooperation of the local government of Lublin with the academic milieu has generated this project or this program. Our cooperation supports the potential and capacity building for teachers, for international networking, for contacts with foreign universities, with Lublin-based academies and institutes. And the presence of professors dealing with the topic of intellectual and developmental disability care is a good opportunity for us to talk about education and cooperation of healthcare professionals. So we hope that today's event will be a good opportunity for transfer of knowledge for intellectual and developmental disability care, and that it will be a good starting point for cooperation between healthcare professionals. The activities of Lublin local government for citizens include equal opportunities for people with disabilities. We want to remove barriers, both mental, cultural, and physical. We want to join the two seemingly separate worlds, and our activities include specialist counseling services, an assistant to a person with disabilities, care services, therapeutical services, specialist services provided in daytime or 24/7 basis. So for us as the local government, patient care is a challenge, both to the local government and to the academic circles. So I would like to congratulate Professor Dobrowolska from the Integrated Care Department for co-organizing the visit and the seminar itself. I would like to wish all the participants interesting discussions, productive exchange of experiences, and to our guests, I would like to wish a good and nice stay in Lublin. As I said before, Lublin is a city of inspiration, a multicultural city. So for you to have an opportunity to see what's going on in Lublin, let me use this opportunity and let me pass over to you the letters from Mayor Krzysztof Żuk and some informational leaflets for you to take advantage of while sightseeing. Thank you very much. Now let me have Mariola Łodzińska, President of the Supreme Council of Nurses and Midwives, and Andrzej Mielik from the Supreme Council of Nurses and Midwives in Lublin. Thank you very much, ladies and gentlemen, Madam Professors. Let me thank you first for this invitation. We had actually the meeting of the Executive Board in Lublin today, and we have some opportunity to sightsee the city. We are under impression, really, so thank you very much. And today's conference is a fruit of good cooperation, and I hope that His Magnificence Rector, on seeing this openness to nursing and midwifery, gives grounds for this conference. I hope that this event will build bridges between us and the United States to learn from our colleagues in the United States. Perhaps it will be an impulse to change something in Poland. So let me use this opportunity to ask Professor Beata Dobrowolska. It's an exceptional opportunity to me. So I would like to congratulate you, Professor Dobrowolska, on the distinction and the title of tenured professor awarded by President of the Republic of Poland. So it's an exceptional opportunity. A nurse is among the top-notch scientific professionals in Lublin, and this is not without reason. I mean, you have an outstanding academic track record, and you are a reference point for all of us. Madam Professor, warm congratulations on behalf of the Supreme Council of Nurses and Midwives, and I believe that these congratulations are from all the participants of this event. Congratulations once again. Let me just add that in this during this term of office, we have appointed an expert council at our Supreme Council of Midwives and Nurses to support international cooperation, and Professor Beata Dobrowolska is a member of this expert council. So once again, congratulations to you. Thank you very much. We join you in congratulating Madam Professor. And on behalf of organizers, I would like to thank all the participants, both on-site and online. And let me now invite you all to the lecture by Professor Brown.
Well, good afternoon. I am delighted to be in community with you all today. I am feeling overwhelmed because your generosity and warmth is something that I would not have expected. Not that I didn't think you were generous and warm people, I just didn't know it. And now I know it, and I'm really grateful to be here. So thank you so much for inviting us to talk with you about this pretty important topic. Talking about individuals, particularly children and adolescents with intellectual and developmental disabilities. I am the executive director, as
Jestem
Beata said,
dyrektorem
the
wykonawczym
Institute for
w Golisano
Developmental Disability
Institute for Developmental Disability Nursing.
honor.
Jestem z tego miejsca zaszczycona, że mogę tę pracę wykonywać, że mogę się dzielić doświadczeniami z Państwem. Jestem tutaj z Państwem między innymi też po to, żeby wyrazić swoje uznanie, uhonorować w ogóle wszystkich praktyków zajmujących się pacjentami czy osobami z niepełnosprawnością intelektualną i rozwojową. Jest mi bardzo miło, że mogę przemówić do takich praktyków, którzy starają się w tym obszarze działać skutecznie. Już Państwo słyszeli, że moja babcia była Polką. To krótki wstęp do tego, kim jestem. Przede wszystkim od strony zawodowej jestem osobą o dużym doświadczeniu w pracy pielęgniarskiej. Pracowałam na oddziale intensywnej terapii dziecięcej. Pamiętam, jak opiekowałam się tymi małymi dziećmi, myślałam sobie wtedy, jaką jakość życia ma taki człowiek, który jest chory czasem śmiertelnie, który jest w szpitalu, który ma problemy z rozwojem. I zdecydowałam się w jakimś momencie pójść ścieżką pielęgniarki psychiatrycznej. Zorientowałam się, jak dużo dzieci, dużo młodzieży potrzebuje takiego wsparcia, przynajmniej w tym obszarze Stanów Zjednoczonych, blisko granicy z Kanadą, gdzie pracowałam. Jako wykładowca zajmowałam się też współtworzeniem programu pracy z takimi osobami z IDD do wieku 22 lat. Zaczynaliśmy z tym programem dla 20 kilku dzieci. Dzisiaj mamy ponad 200 osób w programie, które mają różne potrzeby, których zaspokajamy pod kątem rozwojowym, edukacyjnym i szeroko pojętego wsparcia. Oczywiście nigdy nie pracowałam sama, pracowaliśmy w zespole, pracowaliśmy we wspaniałym teamie innych pielęgniarek, dzieliliśmy się wiedzą. W Rochester też świadczę usługi konsultantki w zakresie choćby opieki podstawowej pediatrycznej. Wspieram młodsze koleżanki i tak jak niektórzy o mnie mówią, jestem też liderką myśli. Przynajmniej taką funkcję pełnię w Instytucie Golisano, w Instytucie Pielęgniarstwa osób z niepełnosprawnością.
He attends the school program that I discussed a few minutes ago. And he is a young guy that after the pandemic, he was increasingly withdrawn. His mother's a nurse and she was concerned. She said, something else needs to be done. And the folks at the school program said, have Reese go see Holly Brown. And so I said, okay, let's see what's happening. The initial concerns about Reese was that he seemed depressed. And people wondered whether or not he was experiencing psychosis, having a thought disturbance. So I'm going to pause the story there for now, but I'm going to come back and tell you a little bit more about him. So when we think about the needs of this population, it's important to understand that in the United States, according to the Centers for Disease Control, we have better surveillance, and we know that developmental disabilities are prevalent in our society. About 1 in 6 children have one or more developmental disability or developmental delay in the United States. About 17% have at least one developmental diagnosis between ages 3 and 17, and about 7%, almost approaching 7%, have 2. So comorbidity is not uncommon for people with developmental disabilities. It's also important to know that when we talk about developmental disabilities, we're talking about a host of diagnoses, right? Developmental disability is an umbrella term. But what falls under that umbrella is attention deficit hyperactivity disorder, autism, cerebral palsy, visual and hearing problems, intellectual disability, of course, and then, of course, I mentioned fetal alcohol spectrum disorder. But that's just to name a couple of the diagnoses that fall under that category. And so, continuing with the need, we know that mental health problems are highly comorbid in this population. Up to 40% of kids in the United States who present with an intellectual disability have mental health problem that's either diagnosed or at a diagnosable level. And that distinction is really important because so often these symptoms go unnoticed or they inappropriately get attributed to the developmental disability or the intellectual disability. This is a term we call diagnostic overshadowing. And I'm here to tell you that diagnostic overshadowing is dangerous. It can lead to not just poor outcomes for folks, but in some instances it can lead to death if we miss it, right? If we miss the symptoms that are happening for folks. And so we can't understate the importance of, and I'm going to say it again, the importance of having an educated, highly skilled workforce that can detect these symptoms and can get us to a diagnosis such that we're getting to treatment for these kids. The other reality when you're working with kids and adolescents with intellectual and developmental disabilities, diagnosis is a challenge. If they don't have language, how do we hear what their internal experience is? If they're showing up with behavior problems primarily, we may get very distracted by that and never really get to the root cause of what may be driving those behaviors. So when we think about developmental, do you all remember the Polaroid camera? Yeah? The developing picture? That's the way we think about kids and adolescents, right? So a kid at 5 today is going to look very different at 7, right? And so some of it with kids and adolescents, particularly with disabilities, we kind of got to wait and see. But the idea is we have to have a keen eye, a keen approach to assessment to ensure that we're not missing anything. And so when we think about mental health comorbidity and intellectual developmental disabilities, we know that roughly 20% of kids with developmental disabilities will have attention deficit disorder, about 22% anxiety disorders, autism co-occurring, 38%, right? Depression, 8%. You should be scratching your head about that low number because it's likely underdiagnosed, undetected. We don't know about impulse control disorder, but we know that impulse control problem's pretty high with this population. And then stereotypic movement, uncontrollable movements, about 16%. But I want to go back up to that third bullet around trauma. Roughly, and I would argue with you that it is an underestimate, 70% of kids with intellectual and developmental disabilities have some experience that is considered to be traumatic. 90% of those kids that were studied had more than one traumatic experience. And so when we think about care for this population, we have to walk into it with an eye towards being trauma informed, being trauma sensitive, wondering what happened to this person and how might that explain what we see in front of us. We know that there's a variety of risk factors, and I'm not going to go deep here, but I want to just highlight, of course, genetic conditions, family situations, parents with their own psychopathology, substance use problems, families that break up from separation or divorce, chronic illness of a family member, the child themselves, just like Reese, born low birth weight and having a chronic health condition. Social factors, poverty and homelessness, social determinant issues are enormous considerations in the work that we do. Stressful home environments. We know that kids with intellectual and developmental disabilities have a higher exposure to child abuse and neglect, particularly in the U.S., and then reduced access to social support to help them along. And then, of course, the things that kids may experience in the community. All of these risk factors set young people up for mental health problems, and the susceptibility for young people with intellectual and developmental disabilities is compounded. So let's talk about what the problem is. I've given you all this background. We have enormous problems in terms of meeting the needs of this population. First, we have to recognize them, right? We have to say, people with intellectual and developmental disabilities are out there. We have to bring them into the tent, if you will, to ensure that they are getting access to care. But in reality, in the United States, and I think I heard that this is true in Poland, there is an incredible shortage of child and adolescent psychiatric providers, right? In the United States, for instance, in a rural state, there is one child psychiatrist to 10,000 children. What is happening with the workforce is that child psychiatry is not a, profession that folks really want to go into. It doesn't make a lot of money compared to surgery or dermatology or something like that. And it's an extensive amount of training for physicians. And so when you look at the data for physicians in the United States, they are exiting the profession to retirement at a higher rate than people are entering. So we have a problem in terms of that aspect of the workforce. The second part is that if you look at any data around child psychiatrists and their understanding of how to take care of people with intellectual and developmental disabilities, their education is low. They have had minimal experiences with the population, and they don't necessarily feel equipped. And that sort of trend is also trended in primary care settings and other specialties in medicine. And so we know that if we're not educated on how to take care of the population, we're not going to see these people in our practices, and we're not going to say, we have to take care of them. In the United States, and I would wonder, after we talk, do you notice this as well in Poland, but we have this problem called systemic ableism, where really able-bodied people are seen and the system is built around them to support them. But if you have a disability, the system doesn't really fit you well. And we see it in all of our places and spaces. So if you go into a building in the United States, for instance, we've had laws on the books since 1990 to say we have to accommodate people with disabilities. But you can walk into a building in Manhattan and the elevator does not accommodate a wheelchair effectively such that a person in a wheelchair could ride the elevator with you and I, okay? And so this ableism is a pervasive attitude or belief that a person with a disability is less than you are an able-bodied person. And as such, it informs negative attitudes and beliefs towards the population that we don't think about including them. This is a big problem in the United States, and we are working hard to stamp that out. Of course, any sort of mental health problem is accompanied with stigma. I'm sure we could talk about that being similar between Poland and the United States. And so that compounds the problem around barriers to care. Because if I don't believe that a person who doesn't have language could have depression, and by the way, this is a family or a provider that doesn't believe that depression is a real thing for adolescents, we're leaving them out, okay? And then inadequate and disconnected community supports is yet another barrier for this population, where a kid is getting care, going to school, and all their PT, OT, speech, and education. And by the way, Holly Brown is there to deliver mental health, is all in one place. And once they graduate from school, what happens is they fall off what we call in the United States call a cliff, where their services are very sparse and hard to access. And so that also adds to the problem of barriers to care. But I want to talk to you about practical solutions, really thinking about what is in hand as it relates to the role of the advanced practice nurse and what is possible with the advanced practice nurse, particularly around caring for this population and ensuring that we are closing the health equity gap for them. So I want to introduce to you what we have in the United States that's called the consensus model. And what it does is it provides guidance to U.S. states to adopt a uniformity in regulation as it relates to the advanced practice provider role. I'm going to just sort of lay this out for you a little bit. And it creates uniformity in terms of how we're licensed, how we're accredited, how we're certified, and how we're educated. And what this consensus model requires is that at the advanced practice level, we all have a title, and that's under the 4 roles that I'll get into. We have a license that says we are an advanced practice nurse based on our state. There are 4 roles that fall under this model: the certified nurse midwife, the certified nurse practitioner, the certified registered nurse anesthetist, and then the clinical nurse specialist. I am duly prepared as a clinical nurse specialist and a psychiatric nurse practitioner, clinical nurse specialist in psychiatry and a psychiatric nurse practitioner in psychiatry. Our education requires us to have completed a graduate level education. It's a requirement. In order to practice, we need to be nationally certified. So we take a national board exam to have our certification. And in the United States, we practice independently just about. So for instance, in New York State, I am not tethered to a psychiatrist to be able to practice. I can open up my own practice, hang my own shingle, practice independently. But for Diane, who's a brand new graduate, she has to work with the psychiatrist for 3,000 hours clinically, and once she's completed those 3,000 hours, she's able to practice independently. And in the United States, I know for sure our European colleagues don't have the same problem that we have, but in the United States, it was a fight for nurse practitioners to get prescriptive authority to be able to prescribe medication. And so where we are now is we call out this idea that we have independent prescribing. We're not regulated in terms of our ability to prescribe by a physician or another entity, but we do have what's called a scope of practice. And I'm going to introduce you to the psychiatric nurse practitioner scope of practice in a minute. So in terms of education and certification, it is vis-a-vis a population focus or population foci. And so in the United States, we have a family nurse practitioner that works from birth to the grave with individuals in primary care settings. We have an adult gerontology nurse practitioner working with older adults, either in an acute care setting, so a hospital-based setting, or in a primary care setting. We have women's health and gender-related nurse practitioner, pediatrics, also acute or primary care. We have a neonatal nurse practitioner, and then, of course, psychiatric mental health nurse practitioner. Now, this sounds great, right? You guys you're excited about this. As it relates to people with intellectual and developmental disabilities, there's no requirements in any of these curricula to ensure that this population is included. And so the wisdom that Diane had around the development of the Golisano Institute for Developmental Disability Nursing ensures we are the people that are saying to the regulatory bodies, you must include people with intellectual and developmental disability. There must be questions on our exams such that the population is included. Because if we don't do that, people say, why is it important, right? It's important because that's my brother or my sister or my aunt, right? That's why it's important. And folks need to be able to be equipped, skilled to take care of the population. So just to bring this down, as a psychiatric nurse practitioner, this is my scope of practice. This is what I'm able to do in my role. So I have a doctorate, but I was able to practice as a psych nurse practitioner with my master's of science degree. As a psychiatric nurse practitioner, I'm trained to take care of people from birth to the grave, but I specialized in kids and adolescents in my practice. My competencies are around assessment, diagnosis, and treatment of individuals who have a psychiatric mental health problem or a substance use problem. Also, I have competencies in physical assessment, pathophysiology, and pharmacology. And then psych nurse practitioners have additional training in psychopharmacology, really prescribing the psychotropic medications. But medication should not be the only thing that we're doing, right? That shouldn't be our only prescription. We also offer individual, group, and family psychotherapy. And I have the distinct good fortune, it's important with people with disabilities, to work with a behavior analyst to sort of help me expand my understanding of behavioral interventions. As a psych nurse practitioner, I'm not just managing disease, I'm also on the side of health promotion. And I would argue that we need to do more of that to be on the side of prevention. Our work is highly interprofessional, working on teams. The idea, who were we talking to? We were talking to somebody today. One of the students talked about the idea that teamwork shouldn't be vertical. It should be horizontal, that we are working together, each of us recognizing what our distinct contributions are to the care of this patient, and that the patient and family is part of the team too, not at the center, in the circle with us, you see? And then, of course, our practice setting can occur across a variety of places. So I had the unique opportunity to practice in a school setting where I'm working with teachers and teachers' aides and other mental health therapists, psychologists, principals. In my life, I could not have imagined that I'd have the opportunity to work with those folks, that they are teaching me as much as I am teaching them and ensuring the care that's happening. And in the U.S., of course, we have insurance that we have to deal with, right? So we have reimbursement in terms of private and public insurance. So that was a lot. You guys doing okay? Yeah, good. So I want to come back to Reese, and I want to show you a little bit about the work that I did with him. So when I met him, of course, most of what I did was observational because he didn't have language to tell me what was happening. So I spent a lot of hours in his classroom observing his behavior, most of which he was sleeping under a blanket, hours for the day in a corner. And when he would wake up, he would carry this very large shopping bag of stuffed animals that seemed to have an obsessive compulsive quality to him in terms of what he was doing with the animals. Sometimes he would line them up in a particular order. Other times it appeared that he got very angry with them and he would throw them or kick them or those kinds of things. And so I got a sense, okay, there's some OCD, obsessional compulsive disorder going on here, but I don't know that that's the whole story. I was struck by how much weight, of course I talked to his mother and learned about things at home, but I was struck by how much weight he lost. And that he had sort of had a wide interest in food and then seemed to have a very restrictive pattern in terms of what he was eating. And his behavior, the teacher said to me, his behavior seemed like he was psychotic. I said, you can't really diagnose psychosis unless the person can tell you what is happening for them. So I don't know that that's actually, we got to be careful about that. But I said to the mother, when was the last time you went to the primary care doc? Well, he goes to the primary care doc frequently, right? And he has connection with his nephrologist often. I said, I feel like there's something else happening with him, and I'm not sure that it's mental health. Are you sure that he feels good? Oh, well, he got his blood work done. He's got chronic renal stuff, but everything is sort of stable. And then I said, okay, let me talk to the primary care doc. I did that. She said he was on an antidepressant. I said, fine, let's not change anything like that. I said, are you sure you don't think there's something happening with him physically? She said, he seems like he's all right. So I said, okay. 8 days later, the mother calls me from the emergency room. She says he's been vomiting for 3 days. I said, oh boy, okay, what do they think's going on? They don't know, they're going to scope him. Turns out he had a eosinophilic esophagitis that had probably been going on for about 8 months, that there was not a whole lot of curiosity about it because he seemed at baseline, but yet he was declining. He came back to school, he was in the hospital, I think 6 weeks by the time they got everything under control. He was like a different person. He was awake. He was alert. He was participating in the classroom. He was, he did not have a lot of language, but they could do hand-over-hand stuff with him in the classroom. And he seemed to have some quality of life. And the teacher says to me, her name was Ann, she says to me, he's eating. He's eating everything. I wonder whether or not we should be giving him all. I said, let him eat. He's lost, 15 pounds here. And at the end of this story, there was actually no need for medication intervention. There was no psychosis. This was a case of diagnostic overshadowing that I shared with you a few minutes ago, this idea. And had I not had the training that I had, could you imagine what we would have chased? And could you imagine what kind of harm we might have brought to him without that careful thinking? So Reese is 22 now. He's going to graduate from our program at the end of the year. The mother is very nervous. And actually, there was no more need for me to be involved. But the mother says, I want you and the therapist involved. I said, okay. So I go to our house once a month and do a home visit. And we talk about what it's going to be like to transition Reese to the adult home, to an adult placement in the next year or so. And it really is just a special relationship that I have with them. And I think the mom has, a deep appreciation for that. So I wanted to share his story with you all. So I'm going to close. I think I'm getting to time, yeah? With just a couple of reminders. We know that kids with intellectual and developmental disability are highly susceptible to mental health symptoms and diagnosable disorders. So we have to be on the lookout for it. And even when symptoms show up that look like behavioral health issues, we also want to take a look back and say, what else might be happening for that kid? Is there something physical? Don't fall into the diagnostic overshadowing conundrum. We know that provider shortages and inadequate educational preparation contributes to poor health outcomes. And we have an opportunity with nurses, in my belief, around the advanced practice nursing role and what's possible in terms of what we can do to help improve the health outcomes for the population. Including the care of people with intellectual and developmental disabilities in our didactic and clinical training is not that hard to do. We have to be intentional about it. We have to provide some forward thinking about it, but it's not impossible. And finally, cultivating high-performing interprofessional healthcare teams is where it's at. I never want to work alone. I always want to be in team. And that has been the secret sauce, if you will, for me in terms of my success both clinically and as an educator. So I think that's all I have to say for today. I think I'll be back, though. These are my references. Please take a look at that. And I really appreciate your time and your welcome. And this is my contact information and our website. So thank you. I'm happy. Question? Yeah? No. Later. Okay.
Bardzo dziękujemy pani doktor za wygłoszone, inspirujące wykłady. Pytania skierowane
this inspiring lecture.
Państwo zadać.
And
Możliwe zadania po zakończeniu.
you have the opportunity to ask questions after we close off the panel discussion, which will be moderated by Diane Kuhneminer, with the participation of the specialists, of experts.
W panelu wezmą udział specjaliści. Dr Jane Tobias, Jefferson College of Nursing, Thomas
Jefferson College of Nursing, Thomas Jefferson University in
Pani dr
Philadelphia.
Renata Ticha, University of
Dr.
Minnesota,
Renata
USA.
Tika, University of Minnesota, USA.
Demon University in Buffalo, New York, USA. Ale także pani
Demon
magister
University in Buffalo, New York. And Mariola Łodzińska, the head of the Supreme Council of Nurses and Midwives, and Małgorzata Kępa-Mitura from the city Lublin, city of Lublin, Health and Prevention Department.
Możemy prosić Zoom?
Dr Jane Tobias, Jefferson College of Nursing, Thomas Jefferson University in Philadelphia, USA. Pani dr Renata Ticha, University of Minnesota, USA. Pani dr Deborah Napolitano, Demon University in Buffalo, New York, USA. Ale także pani magister Mariola Łodzińska, prezes Naczelnej Rady Pielęgniarek i Położnych Warszawa, Polska.
Malutki techniczny problem.
Sorry,
Small
this,
little thing, but it will be fixed. Yes, you can, yeah.
Well, thank you once again for this opportunity to come together with you and to share our work in the interest of people with intellectual and developmental disabilities and their families and their care providers. Oh, here are my colleagues from the United States joining us. As we said earlier when I was introduced, I am the founding director of the Golisano Institute for Developmental Disability Nursing, and for many years in my career, I was an advanced practice nurse in the field of neuroscience. This led me to a significant and important interest in this population that I served across their age continuum, from childhood to older adult, and made me thoughtful and very invested in working to get more and more nurses, hopefully all nurses, with the background and understanding the competencies necessary to take care of people with intellectual and developmental disabilities. Today, with my interdisciplinary wonderful colleagues from the States, we're going to talk a bit more about children and vulnerable children and what's important in terms of their care. And so the first person I'm going to ask to speak is Dr. Jane Tobias, who herself is an advanced practice nurse. She's a pediatric nurse practitioner at Jefferson Center for Autism and Neurodiversity in Philadelphia, Pennsylvania. And Jane is going to be speaking about the importance of screening and surveillance for vulnerable children. So Jane?
Hello, good afternoon, everybody. I'm really excited to be here and looking forward to sharing a little bit about my role as a primary care pediatric nurse practitioner in the care of children with intellectual and developmental disabilities. And we know as pediatric-focused healthcare providers, our focus is on really the early detection, intervention, and ongoing care to promote the best possible outcomes for our children and as they age across the lifespan, as Dr. Brown had demonstrated in Reese's example. As I stated, I am a primary care pediatric nurse practitioner, so I practice in an outpatient setting. Right now I practice alongside a developmental pediatrician in screening children for autism. By the end of this presentation, what I'd like you to take away from it is understanding the importance of early identification and intervention in working with children with suspected or diagnosed developmental disabilities. Applied standardized screening and know when to do the screening across the lifespan so early detection is made possible. And then lastly, and I think while we're all here today, is recognize the value of that bidirectional communication in supporting, developing, surveillance, and intervention. So in my slide deck that you have access to, I put a slide up that really resonated with me. As pediatric-focused nurse practitioners, we have that unique opportunity to influence the health and the well-being of children from a young age. So as Aristotle once said, children are born like blank slates. The experiences and knowledge they acquire will persist throughout their life. And it's our role as providers that are focused on this population to help shape those experiences, particularly in children with intellectual and developmental disabilities, by ensuring that they receive the right care and the right support at the right time in their development. So before we really jump into a little more content, I just want to review some of the terms that I'll be using throughout the presentation. And the first is developmental surveillance. And that is a continuous process of monitoring the child's development over time. The term screening is when I reference the use of a standardized tool to identify those developmental concerns or also to think about those developmental risks. And then evaluation, as we all know, that's that detailed, comprehensive assessment that we use to diagnose developmental conditions. I think the takeaway from all of these terms is to remember that both screening and surveillance are flexible. They're longitudinal. They're going to go across the lifespan. They're continuous and they're cumulative. Like Dr. Brown illustrated earlier with Reese, he was born with fetal alcohol syndrome. He was presenting to her at age 17, and we were still evaluating. We were still being flexible in our surveillance of him, trying to support him across the lifespan. So when we think about that standardized developmental screening, we know that it's the cornerstone of identification of IDD. And as a nurse practitioner, I use this screening at different visits, different well-child visits when these children come in. And I do this because throughout development, particularly those first 2 years of life, children are looking at critical milestones, developmental milestones that they must achieve. So at 9 months of age, 18 months of age, and 30 months of age, I am going to be doing specific standardized screening with them. And then again at 18 and 24 months of age, I do specific autistic spectrum disorder screening called the MCHAT to pick up on those early signs and to further evaluate them. And with screening, the ultimate goal is to identify any delay, any high risk early on in their development, because it's been shown through the research that early intervention, and I know my colleague, Dr. Napolitano, will speak to this in her presentation, is going to make all the difference for the outcomes of our children. In your slide deck, you have an algorithm. This algorithm was developed by the American Academy of Pediatrics. The AAP is the gold standard for myself as I practice as a primary care nurse practitioner. They are the ones that have the best practice, that develop the guidelines for our pediatric population that we follow. And this algorithm is both a screening and a surveillance model. And it was developed with the incorporation of other initiatives which prompted this. So let me see if I can pull this up and share this with you. As you will see here on the screen, we have early identification starting at both the newborn visit and the health supervision visit. And in our newborn care, all our children receive newborn screening, which looks at a variety of metabolic disorders. And across our 50 states, 4 of them are standard, and then depending on the state, other types of disorders are looked at. All newborns will have a hearing screen. And then, as I mentioned previously, when they come in for the health supervision visit, we will do those screenings at 9 months, 18 months, and 24 months to look at any type of developmental disability, such as autism, language disorder, IDD, or any high-risk conditions. This algorithm can be found in my reference section in an article that is listed in Pediatrics. What's important to note here is when you see the blocks that have an asterisk following it, you can also go to the AAP guidelines to gets guidance on how to intervene and care for this population. Next, we're going to look a little bit about the physical examination and developmental surveillance of children. So we know incorporating developmental surveillance into every health supervision visit is vital. We just demonstrated that earlier. And this involves eliciting parental concerns. A parent also brings the results of any screening or evaluation that may be done by an outside professional. And when I talk about this, I mean perhaps testing that's been done in the school system, if it's an older child that is already in school. As I work with students, both nursing and medical students in my own practice, I always tell them that that parental concern must be listened to. A parent spends 24 hours a day, 7 days a week with their child, and they know when something isn't right, or they know when they have another child, if that child maybe is lagging behind. We just have the privilege of a glimpse of time, 15 minutes at these well visits, to try and screen and figure out what may be going on with this child. We're also responsible for getting that developmental history. And I ask you at every visit, whether it's a well child visit or an acute care visit for an otitis media, that is updated and we ask questions about any change in development. When I work with medical students or my family nurse practitioners that see older patients outside of my scope of practice, which ends at 21 years of age, I always say to them, when you're having a visit with an older patient, ask them about that pediatric history. Ask them if they were born premature. Sometimes we forget that once they turn 18 and leave pediatrics, that history doesn't always transfer with them. We want to make sure we get accurate and informed observations of our children. And those observations can occur in the clinical setting, right, in the office setting, but they also should be occurring at home. They should be occurring in school, in a daycare setting, wherever the child is spending time interacting with other children or with their caregivers. It's important to identify those risks, strengths, and protective factors. Dr. Brown touched on the role that the environment, genetics, biology, society, and demographics can play in a child's development. And she also touched on adverse childhood experiences, or ACEs as we know it. And it's been known that toxic stress can make changes to the brain, which can impact the development and behavior of children. So it's very, very important to get a good history. But you know, when we care for children, we're caring for a dyad or a triad, right? We have 1 to 2 caregivers, parents involved in that care. So in essence, we're caring for the whole family. Ask those questions. Document, document, document. I came from a practice with 26,000 children in it. I didn't always have the luxury of seeing my child that I cared for back at a follow-up visit. So it was important that I wrote my thoughts down. If I saw soft signs of the developmental delay, I would note that. If I wanted this child back in 4 weeks just to look at language, I would note that. So the whole team that's caring for this child, whether it's a medical team, nursing, therapy, knows what's going on. And lastly, the role of interprofessional collaboration, which I think is why we're all here today. As a nurse practitioner, I feel very fortunate that I am poised to bring different teams together, that I have the luxury of a little more time with a patient and working in and amongst the different disciplines in our healthcare system. So what happens when we have a screening result that is concerning? When screening results raise concerns, it's important that that thorough medical evaluation is done. And when taking that history, remember to get that prenatal, that perinatal, and that postnatal history. Because we know that if a mom doesn't have enough iodine in her diet, it can affect a baby's development. We know that if a young infant has a high lead level, it can affect their development as well. So get a good history, starting with that prenatal history. Assess motor disorders, reassess hearing and vision screenings, even if they were normal at birth, in addition to any type of metabolic screening. Timely and accurate diagnosis is really essential for guiding appropriate interventions in this population. Referral and diagnosis comes next, and if a developmental disorder is identified, that prompt referral for a more comprehensive evaluation and early intervention is crucial. As I stated earlier, if we're able to intervene from the beginning, it can really change the trajectory and the outcome of children that have intellectual and developmental disabilities. And this extends beyond the home. This extends into specialty visits. This extends into the school system and into family support as well. And again, I just want to leave you with a few key takeaways. The role of the primary care pediatric nurse practitioner and pediatric focused providers is really unique and essential. We know that the early identification of young children with developmental disabilities can be achieved through the combined processes of surveillance and screening, both in the family and in the medical home. So as we see here, these are key points that I touched upon. And we know that the path forward demands continued advocacy for this population, research, and also innovation, thinking outside of that box to be able to ensure that these children are not only supported, but also empowered to reach their full potential, and their families feel empowered to advocate for them. So I'd like to thank you for your time, and if you have any questions, our references are here, and again, I can be reached through my email. Thank you very much.
Thank you, Jane.
Yes.
I apologize that the slides were not available, but they will be available, and we'll make sure that you get copies of them. So,
Thank you.
Thank you, Jane. So the next, our next speaker is Dr. Holly Brown, who's going to speak a bit more around mental health needs for children.
Thank you. So you heard a lot from me already, right? So I'm going to talk a little bit more and just kind of pick up where Jane left off in terms of the role of the pediatric nurse practitioner in the United States in the healthcare system has such an important job around screening, surveillance, early detection. As the psychiatric nurse practitioner, we are much more in a reactive mode as it relates to care provision. And what I mean by that is our care is referral based often, right? We don't have the opportunity to be out front. And Diana and I were talking this morning over breakfast and said, we really should be promoting the psychiatric nurse practitioner to get further upstream as it relates to health promotion for children and youth. In the U.S., where that happens, frankly, is in the pediatrician's office or in the school system. There's a large focus on social emotional learning in school programs in the U.S., especially since the pandemic. And so there we have a much more community focus on health promotion, mental health promotion for kids and adolescents. And I do wonder, vis-a-vis our conversation this morning, whether or not there's more opportunity for us to be exploring that and talking to our leadership in psych mental health to say, what else can we be doing for kids so that it is not so reaction response oriented. So when a referral comes our way as a psychiatric provider, particularly from a pediatric nurse practitioner's office, usually a nurse practitioner has done some sort of depression or anxiety screening with kids with intellectual and developmental disabilities, and they are asking the question, is this diagnosable? How much is this interfering with the child's functioning? How much of this is related to the child's disability? Much like that developing Polaroid example I gave you, right? And so we're trying to look at that again and say, what else may be going on here? Oftentimes, the responsibility is around a comprehensive psychiatric evaluation, usually over 3 sessions, where you are trying to learn from the child, the family, their community, the important spheres of that child's life. If the child has language to tell us, right, we're going to want to solicit that from the child. If not, we're relying fairly heavily on the caregivers and the folks that can report around the child's functioning, really to help us understand how much are these symptoms interfering with the youth's functioning, right? Because that's going to be the threshold for which you're going to make a diagnosis. If I'm a little bit worried after my dog dies, well, we would expect that. But if I am worried after there's been a hurricane, let's say a big storm, and I've been displaced from my home, and now I'm in a stable place, but I still can't get to sleep, and I still have nightmares about what happened. And by the way, during the day, I'm having intrusive thoughts about that. That's diagnosable and is requiring intervention. It's also, as I said, important to understand where those symptoms show up across home, community, and school. And so I think one of the patterns that you see in the U.S., which is a little bit troubling, is because we are not well educated, there is a there's a low threshold for using medication to intervene, right? Using medicines like antidepressants, SSRIs, Prozac, and Zoloft, things like that, which do have FDA indication for use in children. But what it's not so recent, 2010 randomized controlled trial told us is that when we use antidepressants in mild symptoms of depression and anxiety, we actually could make things worse. That was with adults, of course. So a lot of the work is around saying, what non-pharmacological interventions can we use with this population? What skills, more skills, less pills, can we use to teach the child more functional ways of coping, more strategies to manage their symptoms, and really reserve medication for further down the path? Now, I'm giving you an example of a pretty healthy child in a strong family system, has lots of support and has their needs met in terms of housing and food and access to health care. Many of the kids that Debbie Napolitano will talk next, and I work with, are kids that have had those adverse childhood events and that Jane has just described to you, where they are not living at home with their families. Maybe they've been exposed to early neglect and abuse. Maybe they have had multiple school placements and really don't have a good fit in terms of caregiving. Those are the children that I take care of almost very often. And it's complicated because their symptoms have often been overlooked for a very long time. They have not had access to routine medical care, and they show up to me with a list of diagnoses, very long, like this, I'm not kidding, and more than 3 psychotropic medications. And so in that instance, my job is really around figuring out how best to understand what has been done and what hasn't been and what is needed, where there are places to reduce exposure to medication. And this is, when I say this, I'm making the assumption, I'm talking about kids with intellectual and developmental disabilities. This is a very significant problem. So I am often trying to say, what can we do to reduce exposure to medication? Because medication has consequences over time. And how can we provide a more stable experience, both with relationships, school, and community, such that these kids can begin to thrive? And then we look to instill some hope in them in terms of what is happening for them. The good news is we have we are lucky to have a great team around us. There's not a strong evidence base to inform us what to do. There certainly is you know, it's not, I wouldn't, it's evidence, as I said, evidence informed to give us guidance about how we want to proceed with care. But in lots of ways, as I said in my keynote, you know, having a team around you to really problem solve together to figure out what is the best path forward for these kids is really where it's at. So I think I might be about what I have to say, Dr. Cooney-Miner. All right, great. So thank you.
Thank you, Holly. You know, as Holly mentioned, and you know, we'll talk about even more now, is the importance of the interprofessional team, and that we do this work together as a team because it is complex, and we understand and recognize that the way we serve this population best is through an interdisciplinary interprofessional focus. And so I want to ask Dr. Debbie Napolitano to join us now. And hopefully we can get her slides going. Yeah. Debbie works closely with us. She's an applied behavior analyst. And when we met with the students today and talked, I think that terminology was not necessarily familiar. But it's a major, there's a major contribution that happens to the welfare of children and families in the United States because of the great knowledge and expertise of applied behavior analysts who really work to focus on improving communication and behavioral skills over time for persons with intellectual developmental disabilities. And the other part that any of us who work with children, with pediatrics, know that really in many ways our client is the family, not just the child. And so I've asked Debbie to talk a bit about her work in support of families of children with special needs. So Debbie? Slides made it.
Okay, can you hear me?
Yes.
Okay. Awesome. Thank you. Thank you so much for inviting me to be here. This is really wonderful, and I wish I was there in person. I am really honored for you to be here with all of you, and really appreciate the introduction from my colleagues. I am a licensed behavior analyst in New York, in the United States, and there are some resources in Poland for behavior analysts, and I will share those at the end. I'm going to focus today on the things that could potentially be done to support and educate and education for families of young children with developmental disabilities. As a really, I feel, fortunate member of this interprofessional team, and I say that very deliberately because interprofessionalism is really the key to supporting these the families and individuals with developmental disabilities around their needs. As Holly correctly identified or indicated, I also work with individuals who have serious health issues and trauma histories. Most of the kids that I work with are are in our child welfare systems here in the United States, particularly in New York, and also our juvenile justice systems. And I couldn't do this work if I didn't surround myself with an interprofessional group of individuals, because this isn't these kids don't require just one person to work with them. They really require a team of people for us to be supportive and effective. I'm going to start just talking about some of the things that I see as needs in some of the kids that I work with, and then I'm going to try to address each of these needs with some potential solutions or things to think about that we might do to help support them. So we know that, and as both we've heard from Holly and from Jane, that some of the youth that we work with have communication challenges, which can really get in the way of their being able to grow and thrive. And what we sometimes see is a delay or total lack of development of spoken language even when children engage, can have what might look like spoken language, they might have difficulty with social cues, those nonverbal things that we communicate, even with our facial expressions, or as I'm using my hands right now, those nonverbal things that we do to communicate might be difficult for kids with disabilities to really pick up on. They also might lack some of those typical social communication skills, so that back and forth conversation that you might have with somebody. And even so, they also additionally might struggle with initiating communication. So we sometimes see that kids might repeat things over and over. And sometimes that's because they're trying to initiate a communication with you, but they don't really know. Sometimes also we see that kids have a literal interpretation of language and they have difficulty interpreting slang. So one of the recent slang terms that the kids here in the U.S. are using is "I ate that." So "I ate that" translates into "I did really well," but if you say "I ate that," people are going to think that you're actually eating something. And so it's really hard sometimes for kids with disabilities to understand the slang terms. And finally, they might be slow to react or respond, and we don't often give them the time that they need to process some of that auditory information. And what can happen with families is when these things when kids are struggling with these things, is that they can then become concerned, frustrated. It can be really hard to communicate for the child with their family, and for the families with their child. And so we need strategies for how we can help with these things. And so some of those strategies include, just really observing. And I think families often do this naturally, is you get used to seeing what your child is trying to communicate by them using their body language, by pointing, things like that. But families can also put words to things. And I think that sometimes because kids, when they're developing language naturally, we can see that they're able to, to start to put words to things themselves. But with what we can do to support kids is to put words to things ourselves. We can say, okay, you're trying to tell me, and then fill in the blank. Another thing that's really important is to remain calm and empathetic. So it's really easy to get flustered when we're trying to help somebody engage in communication. But if we remain calm and, let them know, I understand you're trying to communicate with me, that can really, really go a long way. We can use visuals and pictures as representations. We can use objects, so we can show them something. Well, you're trying to tell me you want the phone. That's my easiest thing to go to, to show you. We can also write things out to help individuals who can read but have struggled with actually being able to communicate. And we can use stories and scripts so that that can also help them. The other issues that individuals with disabilities might have is perspective taking, so viewing a situation or understanding the concept of from an alternative point of view, because sometimes that's one of the things that goes along with some of the diagnoses that Holly and Jane talked about, is that you can't really view the situation from somebody else's perspective. Similarly, empathy can be difficult sometimes for persons with disabilities. So the ability to understand and share the feelings of others. And that goes along also with executive functioning, viewing sort of self-regulation, problem solving, and organizing and planning. And what that looks like is that we have sometimes kids can have difficulty with transitions, poor organizational skills, difficulty working with peers, poor problem solving skills or thinking outside the box, and challenges with understanding what others expect of them. And so for those there's additional considerations and possible behavioral concerns that they might take longer to learn skills. Skill development may require multiple interventions to scaffold learning and functional use of skills. They also might require intensive instruction, and that's something that sometimes is forgotten, is we need to repeat the instruction multiple times. Individuals might be easily distracted and motivated to attend to things other than instructional materials. We can see sometimes disruptive behaviors, difficulty sitting still. In some specifically, particularly for our kids who have trauma histories, they might have a lot of difficulty listening and understanding what's going on around them because they have so much else going on in their lives. And in worst case scenarios, we might see aggression or self-injury. One of the things that we see often in persons with autism is what we might label elopement or running away, which can be very serious, as well as things like pica, which is eating inedible objects. And much of these go back to issues with communication. And so it's really important that we involve folks who can help us understand the issues around teaching someone how to communicate what it is that they're trying to say. Because informed treatments begin when we understand the why of behavior or why behavior occurs. Holly talked a lot about the needs of individuals when we're talking about non-pharmacological interventions. And so we can start with trying to figure out why somebody is engaging in behaviors that we're seeing. So throwing objects might communicate that I've had enough. I'm done with this particular lesson or this particular activity. Screaming might actually communicate, I want something. Or hitting a peer might communicate, leave me alone. It might be the only way the person knows how to communicate. And so what we're trying to do when we're trying to figure out the why of behavior is to figure out why somebody's doing something, because often they're trying to communicate to us and they don't have the words to do so. So how do we address these particular communication and social, emotional, and additional challenges? We need to think about multiple ways that we teach, and this is where it's critical that we have the interprofessional team so that we have teachers and speech therapists and behavior analysts and nurses and all of the folks who may be able to help figure out different ways that this individual or this child can learn. We need to modify the instruction based on how the person learns. We need to teach to how they learn, not teach just the way that we teach every child, because each child is different. Usually and often, one of the things we need to do is to break the skills down into smaller parts. We need to prepare the students for transitions and for unexpected changes by giving them warnings. Sometimes that can look like, okay, right now we're going to have this unexpected thing that's going to happen, or that just happened. We just had a fire drill. We have those often in the United States, or we just had this thing come up that we have to do for our family, like go to the doctor. And so what this is going to look like is we're going to get in the car and we're going to drive to the doctor. We need to do the assessments as Jane indicated. And one of the assessments that we can do related to behavior is called a functional behavior assessment, to understand, again, the why of behavior, what is going on in the environment. And again, we need to really refer to, ideally, an interprofessional group of our team members, such as speech therapists for teaching how to communicate, psychologists for social and emotional concerns, or behavior analysts for understanding the reasons why behavior might occur and designing really effective strategies. So some of the things that we can do, just some of the practical things, is we can give reminders. So reminders can be visual, such as the one that I have here. Stop, pay attention, do your work, and great job. This can act as a reminder for a child of things that we might be looking for them to do that might help them remember to get their work done. We can break things down into smaller tasks. As I said, here is a visual written task analysis for shoe tying. Grab one lace in each hand, pull the shoelaces tight with a vertical pull, cross the laces, pull the front lace around the back of the other, put the lace through the hole, tighten the laces, and make a bow, and then tighten the bow. I put this in here, this picture of Lego instructions, because they are excellent at giving visual guidelines in how to make something or how to proceed. And we can use these kinds of visual guidelines in all of our instruction. You can see they have really nice step-by-step visuals. Here's step 9, here's step 10, 11, 12, 13, and 14. We finally have our blackboard. And so again, these are really nice visual representations of how we can teach. Oops, sorry, I went too fast. And another opportunity that we can use visuals is for problem solving. So it might be a little difficult to see, but what we have here is we come up with potential solutions to a problem for a child. Again, really thinking about how do we use visuals to help a child through some of their struggles. So, okay, here's our first solution that we're going to come up with. What are the pros and cons? And let's count up how many pros and cons we have. Here's our second solution. Let's count out how many pros and cons there are to those solutions, etc. And what that can do is help us identify what the best solution for a particular problem might be. And we can see the pros and cons visually for a child. We also talked about difficulty with schedules and transitions. Here's an example of how you can do a visual of a morning schedule. So today is Tuesday. I am going to school. First, I'm going to wake up. Then I'm going to make my bed, wash my face, get dressed, and have breakfast. After breakfast, I'm going to brush my teeth, brush my hair, get my backpack, put on my coat, and wait for the bus. This is a visual representation that can help a child really understand what to expect. You can do this kind of visual representation for any task or any activities that they are engaging in. And this can really help them feel comfortable and confident and reduce anxiety and stress around their schedules for the day or schedules for any particular activity. It also helps increase independence because they can look at this and know what to do rather than somebody needing to be told. And that's really a nice way to improve autonomy because they are then able to do this on their own in many cases in a lot more independence. So these are just very general strategies that I offer for some of the concerns that you might see for kids with disabilities who struggle with communication challenges. And that is often the case for kids in a variety of ways. But if you're really in need of understanding specifically the why of behavior or how we can help, again, that's where I would refer to that interprofessional team. And if you're interested particularly in behavior analysis, you can certainly contact me at dinapaulett@damon.edu. But there's also some resources in Poland. There's the Polish Association for Behavior Therapy, and you can find that at this link. I'm certainly happy to share that link with you. I can put it in the chat for folks who are interested. And there's the Polish Society for Behavioral Psychology. And both of these could potentially offer some resources specifically around behavior analysis in Poland. Thank you very much. And I'm, again, very grateful to be here.
Thank you so much, Debbie. Our final presenter is our fabulous colleague from the University of Minnesota, Dr. Renata Tika, who's a research scientist in the field of special education. And, you know, one of the most important persons in a child's life is their teacher. And so I asked Renata to say a few words about her own work in special education and ways that we can help support teachers as they support these children. So Renata?
All right, dzień dobry. Thank you very much for having me on this panel. As Diane said, I work at the University of Minnesota. My background is in special education, but I also work with adults with intellectual and developmental disabilities. Today, I'm going to talk a little bit about the role of teachers and the education system. So, I work in different parts of the world, even though I am located in the United States. I am originally from the Czech Republic and have worked in an orphanage and a special school in the Czech Republic prior to moving to the United States. So from my experience, in many countries, specifically in Southeast Asia, my experience is mostly from India and Bhutan, is that the support system that is supporting a child with a disability is the family and the community. On the other hand, in the United States and Western countries, we rely much more on the professional system that might be paid through insurance or through various other systems. In the United States specifically, the support, as was already mentioned before me, in the interdisciplinary, interprofessional manner is through the education system, even in early childhood. And so in the United States, through the Individuals with Disabilities Education Act, or IDEA, there are two provisions that specifically talk about infants and toddlers and young children with disabilities and the supports they need to get through that system. The special education teacher and the teacher are very important members of the interdisciplinary teams in that manner. Now, one thing I'm going to say, my experience of comparing the Czech Republic and the United States is that the United States has an advantage in that a lot of the interdisciplinary, interprofessional work dealing with children with intellectual and developmental disabilities happens in the same building, and that is the school. In the Czech Republic, I'm not sure how it is in Poland, a lot of this work happens in separate assessment psychological centers where the parents need to bring the child, and there is not that continuity and the time and space where everybody sees the child in the same space. So I would say that's one advantage of the United States system. The document that guides the support for the child with a disability is the Individualized Family Service Plan when the child is very young, that outlines the services, the time for the services, and the person who is actually going to provide the support to the child. Among those services, under early intervention, we can see things like audiology, vision support, speech and language, psychological services, physical therapy, assistive technology, social work, and the coordination of services. So right there and then you can see the interdisciplinary interprofessional approach. The other important person, of course, is the nurse. And that's one of the really advantageous pieces of the US system, is that the nurse is located, may not be 100% of the time, but within the school. And so the nurse becomes automatically part of the system within the education setting. One of the other provisions of IDEA is that the supports are to be provided to the maximum extent possible in natural environments with other children without disabilities. And therefore, the education setting with other children is very important for the child with the intellectual and developmental disability. As far as the supports and the role of the teachers and other educators in early childhood, the roles are screening, referral, and identification of disability. As was already mentioned before me by Holly, the teacher is an observer who is looking for potential signs of a developmental delay. There is actually a term in the system, which is the child find. So that's one of the roles of the teacher, is to find the children who may have a developmental delay that has not been noticed before. The other roles include instruction in social skills, daily living skills, and pre-academic skills. Obviously working with families, that Debbie highlighted, and being an important part of the multidisciplinary team that was already mentioned. The educator of children with disabilities in inclusive setting need to have a very, very high level of flexibility and versatility, and there is a high risk of burnout. And so the research has indicated that to mitigate burnout in educators who work with this population is the interprofessional work, being supported by other colleagues on the team, having access to professional development, to the newest trends, what's happening in other parts of the world, other parts of the country in the field, positive school environments, so having support at the leadership level of the principal, of the assistant principal, of the other teachers in the school. Then the school has a sense of community where the teacher feels supported. And the other part that the researchers highlighted is that when the teacher is feeling commitment to the job and really feels like they are making a difference, that also mitigates burnout. So thank you very much. I'll be very happy to also be a resource for the education side of things for children with intellectual and developmental disability. Dziękuję.
Thank you, Renata.
Teraz chcielibyśmy zaprosić do głosu panią prezes Mariolę
Now
Łodzińską.
let's have Madam President Mariola Łodzińska to take the floor.
Szanowni Państwo, ja muszę powiedzieć, że pielęgniarstwo w Polsce jest zdecydowanie na innym poziomie niż w Stanach Zjednoczonych. Może nie tyle gorsze, co zupełnie na innym poziomie. My w Polsce, proszę Państwa, żyjemy od wyborów do wyborów i kontynuacji władzy, to, co zadzieje się dobrego w ramach jednej władzy, niekoniecznie jest kontynuowane.
In one term of office usually tends to be dropped in another term of office, or when the party in power changes. So it's really difficult for us to pursue a project with a success, or bring it to a fruitful end. I must say that Polish nurses back in 2015 got the privileges to prescribe medications and continue the treatments, and it's even at the the bachelor's level and Master of Sciences level, it's normal that nurses get these powers to prescribe medications. But as far as the general approach to the patients, children and adolescents with IDD is concerned, well, I must say I'm impressed that our American colleagues can simply focus on thinking on the patients. The pressures that we experience in our profession are quite different. There are no standards for employment of nurses and midwives, and the load of patients assigned to a single nurse actually prevents us, from in-depth investigation, identification, and care and treatment of those patients and their families, just to solve the problems effectively, or to refer the patient to the proper specialist. So, according to the international categorization, in Poland we have kind of 4 levels of developmental disorders. But what's important is that in Poland we focus more on institutionalized care, and of course we have plenty of care homes for children and adolescents with IDD, and there the work nurses that report not to the Ministry of Health, but the Ministry of Labor and Social Policy. And of course, this has its repercussions, if only in terms of salaries. So nurses in care homes are paid significantly less than those nurses working in hospitals or primary care units. So our problem is that nurses decide en masse to actually to move from the care homes to hospitals because of the salaries, the low salaries. So we are facing now a fierce debate on how to cause our colleagues in social care homes to stay there. They are very experienced, highly skilled, but underpaid, unfortunately. So this institutional or institutionalized care focuses on the comprehensive 24/7 care, but what we miss is the daycare and interdisciplinary support from other groups, other specialists in social care homes. The nurse is the central contact point for identifying, diagnosing, and treating the symptoms, but without any support from external specialists. I must say that just like in the US, we have school nurses employed there, although what we used to have is that every school had a nurse, a dentist, and a physician. That was back in the 90s of the 20th century, where our system evolved, and now school nurses are mostly providing services as individual practice or group practice, and it's only kind of strict nursing care that they provide. Another problem that we have is with the provision of these services and reporting. So for the testing and identification and what we report is from screening, for instance, is completely different to what we have in our notes, in our notebooks. What we actually need is to have the system for the history taking, for the note taking to be digitized, so that we can share our insights with both our supervisory authorities, the Ministry of Health, the Ministry of Labour and Social Policy, but also the local governments, the local authorities and local support centers, just to be able to design specific care programs to address the needs of both individual children and their families, so that the support can be easily accessed to such disprivileged families. I think that our problem is quite similar to what our American colleagues have. In Poland, more nurses, actually leave the profession than, enter the profession. However, I must say that, that overall the salaries have increased recently, and I must say that part of the nurses who decided to retire previously now want to come back to work. So it's a value, it's an added value to the nursing society, so to say, in Poland. And we'll have our tradition continued. Still, we will struggle with the problem of kind of uneven distribution of resources, of personnel. Lublin is a place where there are a lot of universities, a medical university, and a lot of nurses graduating from the departments. There's no problem with availability of nurses in this voivodeship. However, in the Lower Silesian the region, for instance, next to close to Germany, well, most of Polish nurses would go to Germany because of free accommodation and better pay. So it's a huge problem for us on how to bridge the personnel gap, the resources gap for nursing community in Poland on a kind of evenly across the regions. And the availability or the access to nurses depends on the regions, and there are the differences in the numbers of children, per nurse. This is also a problem. Still, I would underline that no digital solutions in Poland is the biggest problem. Not only in nursing, it's also about schools themselves, it's about the long-term home care, where the nurses and midwives work. And also in primary care. So this is yet another component where nursing providers, and we have specific feedback from that from the National Health Fund, the nursing providers providing services in patients' home and monitor the family condition, the family status. In 80% of the time spent at the patient's home. However, the majority of nursing providers and
raczej wykorzystują te
medical
do pracy
providers
w
that employ
gabinetach,
nurses,
jeżeli,
well, they would use,
gdyby możliwość realizacji tych świadczeń w domu pacjenta i to nie jest wina
they
pielęgniarek.
will use nurses in the surgeries without letting them out to outreach the vulnerable groups. So it's yet another point where we see a need to invest in nursing providers going digital,
to, czym się zajmujemy.
to be able to provide our services effectively and to effectively communicate with all the stakeholders.
Uczniami przewlekle chorymi i niepełnosprawnymi. To jest wykonywanie i interpretacja testów przesiewowych, ale też
also do is the screening and interpretation of results in the first place, but we also
testów, ale to jest też udzielanie pomocy przed
referrals for those that have been diagnosed with certain conditions, but we also provide direct nursing services in acute cases, and now will be involved in the health education. That is a kind of a new curriculum that is going to enter the Polish the schools. As far as we know, the Ministry of Health will actually provide for employment of nurses and midwives in teaching the pupils. So what's the trend, the overall trend in the nursing community? We can say about ourselves that we have the power of change in ourselves. So, when there's an accreditation of something in hospital, it's mostly successful, whichever hospital you go to, because the nurses have prepared all the process excellently. Now, we want to improve the process of qualification of children for vaccination, for instance, because, on top of the mandatory vaccinations, of course, the prevention is key to the overall health status of society, I must say. So it's yet another projects that we pursue. Now we see that we need to act in terms of negotiations with the Ministry of Health for reimbursement of costs of care for IDD the patients, and we need to fight for the possibility to arrange interdisciplinary teams or simply availability of experts for us to get support with the specialist knowledge that they have and we don't. This kind of care can also benefit, the disprivileged communities. I mean, those communities across Poland that have difficult accessing healthcare itself. Then we have a lot of experience in coordinated healthcare that is becoming a major trend in primary care in Poland today, where patients will be given care, from the first step, and then guided through the system with specialists that need to be consulted, in specific cases. So, in our opinion, there's a huge potential to be tapped into from AI. If only in teaching the conversation skills for patients with the IDD. Last year we had Queen Sylvia, the Queen of Sweden, competition And last year, the nurse Adrian Nowakowski actually, was awarded the highest prize for that, for a project of AI use in communication. So it's an excellent project, and there's a lot of potential. Adrian, well, he's a nurse himself, but is a promoter and actually he's keen on AI, and he studies IT just now. So we see a lot of opportunities in there in AI. But for us to be able to develop and build capacity, we ourselves need to be evaluated, we need to get educated, and we need to be supporting our colleagues. Perhaps the problem in Poland is a bit different. Holly mentioned the quality of education. Well, it's a similar situation as we have a lot of centers, educating nurses and midwives, but not always the education or graduation actually results in the skills or competence level that would allow them to work successfully, effectively with the patients. Perhaps that's a good postulate to the authorities of the medical universities, just to focus on the quality of teaching our personnel. Thank you very much. I would like to end with this comment. Thank you.
Bardzo dziękujemy pani prezes. Teraz zapraszam panią magister.
Thank you, Madam President. Our last speaker, Małgorzata Kępa-Mitura, Deputy Director of the Department of Health and Prevention, Lublin Municipality. Hello, everyone. Before I tell you more about what the city does for IDD people, first I'd like to take you to the land of dance. I'll show one of our social initiative pioneered by Piotr Mochol, Deputy Director of our special school number 26 in Lublin. At the same time, he's an artistic director of dance ensemble Klanza from the Lublin Technical University. So here it is.
Wszystko mi gra z tobą, lepszy ten świat, bo mogę być w nim sobą, z tobą, mogę się śmiać z tobą, jakoś mi tak po drodze. Gdy bratnie dusze przyciągają się tak, to niemożliwe nagle można od tak. Z tobą wszystko mi gra, z tobą lepszy ten świat, bo mogę być w nim sobą.
Znasz mnie tak dobrze, rozumiesz bez słów i trudne jest proste, gdy mam ciebie tu. A kiedy mi szaro, rozstawiasz do łez, odlasz tak samo, nie boję się, że
Raz się nie ma, a raz ma, życie to ruletki gra, ale z tobą zawsze dobry kolor. Razem mamy super moc, super skład, jest super bok. Gdziekolwiek jesteś, zawsze będziesz obok.
Gdy bratnie dusze przyciągają się tak, to niemożliwe nagle można od tak.
Z tobą wszystko mi gra, z tobą lepszy ten świat, bo mogę być w nim sobą, z tobą mogę się śmiać z tobą, jakoś mi tak po drodze. Gdy bratnie dusze przyciągają się tak, to niemożliwe nagle można od tak. z tobą, wszystko mi gra z tobą. Lepszy ten świat, bo mogę być w nim sobą.
W swoim wstępnym wykładzie, że
Professor Brown said in the opening lecture that persons with disabilities should not be excluded, taken out of their setting, of the place where they live. So the city of Lublin struggles to maintain and promote inclusivity so that every resident can feel safe, can feel at home, live whatever they like to live. So when getting ready for this talk, for this meeting, I had a look at some strategy papers of our city, particularly the strategy of resolving social challenges and strategy for persons with disabilities, and a program of protection of mental health covering the years 2025 up to 2030. When we look at some statistics that were behind these strategies, we have several dozens of thousands of residents with disabilities. Among them, a few thousand are persons with mental, intellectual disabilities. This data doesn't even give the full picture of the situation because some people don't say or are not required to say openly that they are disabled or not. We can only rely on the census data and disability certificates collected by our municipal disability certificate team. So this data is not full. Many people are not certified as disabled, and this is particularly visible among seniors. Recently, we have completed a program of support for the so-called respite care. And one of the criterions of entering the program was having disability certificate. So people without such certificate were denied entrance in the program. So we noticed that gap, that some of the residents of Lublin are not diagnosed and not certified as people with disabilities. So in other words, they are denied support because many forms of support are hinged on having that disability certificate. And the same with some welfare assistance, because many groups of people with disabilities, including those with mental disabilities, are very often people seeking financial support from the municipal family assistance center. So how the city supports persons with disabilities? Well, within the structure of our administration, we have health and disease prevention department. We have a division for persons with disabilities. They run an information point. They offer guidance concerning support, where support can be sought depending on your needs as a person with disabilities. We also have a department of social initiatives, mainly working with NGOs, some of them also having persons with disabilities on board. And also the mayor of Lublin has appointed a representative for persons with disabilities. This person basically monitors and takes care of accessibility within the city tissue for such people in particular. There's also an advisor to Mr. Mayor on problems or needs of persons with disabilities. The point is to help them feel full-time residents of Lublin. We have also a number of city institutions such as Family Assistance Center, the Municipal Disability Certificate Team, Labor Office, that are also very supportive. We try to take care of these clients if I may put it like this, from very early age until seniority. Now, more and more, we are facing challenges related to elderly people. In the past, it wasn't a major challenge for medical or healthcare facilities. For example, persons with the Down syndrome, who usually die relatively early, but now they live more and more. They are well into their 40s or 50s. So the barriers that we are facing, I believe we should look at as certain strong points. Lublin, as a city of inspiration, struggles despite many limitations like laws or finance or shortage of resources. Our activity mainly focuses on the resources from our organizational units, but also we rely extensively on the support from NGOs. And this is very, very strong cooperation. Many formal legal limitations that we face as local government units. Sometimes we cannot do something as administration. This is where NGOs can enter with their initiatives, with their capacity. And we are very happy to see that. When it comes to, for example, city nurseries, the city has 9 nurseries for children with disabilities. This is where also nurses work. They, for example, diagnose children for autistic behaviors. Next level is preschool institutions, kindergartens. The problem is kindergartens don't have nurses permanently employed, which is, of course, a problem because the child having a problem with health, with mental health, cannot just jump from nursery to school because there is a major break in assistance, and the lack of assistance, the lack of diagnosis really affects adversely the patient, the family, and may even aggravate certain conditions. As regards the school level, we have few schools in the city. Sorry, we have nurses in almost all elementary schools, but unfortunately they are not there on a permanent basis. They only come at specific times, which is of course not enough if you look at the actual needs of students. Well, we cannot do more of this because of legal restrictions. Sometimes we manage to send nurses to schools, to special schools, sometimes with the support of parents, but very often we fail, even though parents are ready to pay for that. This is unfortunately illegal. This would be a double income for the nurse, which is banned by the law. Another place, another institution that I want to talk about is family assistance centers. Of course, financial constraints is major problem. Nurses are, of course, the number of nurses is on the decline. Many nurses are either about to retire or they should even retire now, but they decide to stay to continue their career, or sometimes they just come to work just for a couple of hours a day, a couple of days a week to earn some extra money besides regular pension. Of course, they were very, very a valuable resource during the pandemic, the COVID pandemic. I was then a coordinator, epidemiological coordinator for city units, and we did a lot. We had very professional teams in place, very professional consulting conversations, including at schools. So what have we managed to do beyond the standard expectations or standard solutions? Of course, we have self-help institutions. This is everywhere in local governments. So we have introduced the services of personal assistant. This is particularly intended for autistic persons with mental disabilities. We want to develop the whole unit, a facility where round-the-clock services will be provided, where patients might even stay for long, depending on the diagnosis, for example, if they cannot be on their own. But also such a facility will offer the so-called day rooms, where people will only come in the morning and leave in the afternoon. Also, this facility will be open to families, relatives who would like to get involved in providing assistance. We want to deinstitutionalize the system of care because it is both cheaper, but on the other hand, we would need more support from non-professionals in general. Last year, we started a project launched by the WHO, which supports non-professional carers. It was a great support because such non-professional carers can focus not only on the needs of persons with disabilities, for example, people with mental disabilities, but sometimes the problem is they ignore, cardiological issues, because people with mental disabilities sometimes need to consult a dentist, to consult an oncologist, to get vaccinated. And non-professionals cannot always do that or cannot always predict that. I know such patients in various facilities across the cities. So anyway, we try to put these non-professionals together and offer extra training on obligatory vaccination, for example, or reading some signs. Also, parents can be among this group of non-professionals. Now, another initiative of the city is called Safe Teacher, Safe Student. We did a pilot in a school that specializes in working with autistic students, because autistic children are very often unpredictable in their behaviors. And if the carer is, 5 feet tall, and a young man, agitated man, who is 6 feet tall and, 80 pounds in weight, then the safety of the carer is at risk. We have also a self-help facility that has a special lab. It was also paid by private sponsors. This lab is intended for children with the Down syndrome or autistic children. This is a visual studio where you can imitate swimming in a lake or in a pond or in a river. So if only you have people ready to help, everything can be done. So what we're trying to do is to win the support of sponsors, of groups, communities, for example, by organizing events when they can come together. I think the greatest value is when you hear thank you from the child, from the parent, from their relatives. And going back to the video I showed you, one of the patients said, "I like dancing in this academy. I like to feel on stage like a fish in a pond. On the stage, I feel like a real star." Thank you.
Bardzo dziękujemy za owocny panel.
Well, thank you, all the panelists, for your contribution. I believe you have been encouraged and inspired to follow up and maybe improve your practices. We have heard a lot about the needs of persons with IDD, but also about their carers. So who knows, perhaps that might be a great starting point for upgrading curricular programs of training also of such individuals. Thank you all for sharing, and some closing remarks now from Dean Wysokiński.
Szanowni Państwo, bardzo miło Państwa gościć w murach naszej uczelni.
Ladies and gentlemen, I'm very happy to have you here at the Medical University of Lublin, at our Faculty of Health Sciences. Thank you very much for accepting our invitation, for coming from behind the ocean to take part in our meeting in the flesh. And I want to thank all the speakers on-site and off-site, the audience, and everyone behind the organization of this meeting. As the university, the faculty, we want to be a point of support that brings together theoreticians, practitioners, local government activists, professionals. We want to be also a reference point for others. For many years at the faculty, we have known that good quality healthcare, but also social care, wouldn't be possible without bringing many people, many communities together who want to work for others, for the good of others. And it doesn't matter whether we have finance or not, these people bring their heart, their time to help persons who are in various ways limited in their actions, in their choices, in their abilities. So thank you again very much for this seminar. It's not a conference yet. Perhaps we should consider having a bigger event. Seminar is usually directed at a narrow group of recipients interested in a narrow area, but I believe this is not such a narrow area because there is huge interest behind it. We are very interested to hear about American solutions. We are very curious, of course, to learn more about our local solutions, including those by the local administration. And this event wouldn't be possible without the support of many generous people and institutions. I'd like to thank the Supreme Chamber of Nurses and Midwives. Thank you for your support right from the beginning. I'd like to also thank the local branch of this institution. I'm afraid the head of the local branch is no longer with us, but also she's been very, very helpful in obtaining the visiting professor grant. I want to thank also the mayor of Lublin, Mr. Żuk. I will speak to mayor that next year perhaps he would like to shift focus more to midwives. I want to thank the technical team behind our streaming, our audio, and finally I want to thank Professor Beata Dobrowolska. I know, well, she keeps repeating, it's always the team behind it. Of course, I'm fully aware of that, but at least, please you, Professor, accept my thanks for this work, for the organization. So, am I supposed to finish now? Yes, I know we are pressed for time, so I hereby pronounce the seminar finished. Thank you.